Good afternoon, everyone. My name is Dr. Rob Murphy, and I'm the Executive Director of the newly renamed Robert J. Havey, MD Institute for Global Health, or the Havey Institute for Global Health. This is the first time we've had a First Friday seminar using actually our new name. Anyhow, I'm the Executive Director. I'm a Professor of Infectious Diseases and the John P. Fair Professor of Infectious Diseases. Thank you very much for taking the time to join us this afternoon in our latest installment of the Havey Institute for Global Health First Friday seminar series. The title today is Strengthening Primary Care and Global Health, a Call to Action. Please take a moment to follow us on Facebook and Twitter at #FSM Global Health. In addition, we welcome you to become an Institute member to receive access to specialized resources and services that support research infrastructure. And for more information, please visit our website, globalhealth.northwestern.edu/members. Now I'm going to turn the podium here over to Dr. Havey, and he is going to introduce our speaker for the day, Dr. Lisa Hirschhorn. Bob?
Yeah, thank you, Rob, and thanks everyone for attending today. We're really fortunate to have a wonderful participant and partner in our global health efforts with Lisa Hirschhorn. And before I introduce her incredible credentials and how impactful her work has been in global primary care, I just wanted to make a quick comment about the new gift that has come into the Institute. For those who've been following us for a lot of years, you probably know that we've had a student travel experience, an education experience, a lot of clinical care, and a lot of research. And Rob Murphy and myself have co-led these efforts from different directions. We came together a few years ago to form the Institute of Global Health, and our goal was to grow the Institute into really what we continue to have as a goal, is to grow it into the world's leader in global health. And last week, this enormous announcement by the Pat and Shirley Ryan family has really put us on a great trajectory to accomplishing that goal. The unusual thing about this gift is that most people who really help endow things like institutes at universities have the namings put after them. The Ryans, almost a humble and almost embarrassing way for me, wanted my name involved, and they wanted it really not because of me as an individual, but really because of the prototype example that a few really dedicated people like Rob and myself and all of our Institute faculty, Lisa included, have really been pushing this effort for decades. And this naming is just a recognition that it's really the folks on this team that have moved this institute along to its current level, and this team will move it along further. You're going to hear some great things today from Lisa about primary care. In addition to the funding of the Institute, the Ryans are also planning a gift to global primary care, which will really help us pursue this. Primary care has been near and dear to my heart because I'm an internal medicine physician at Northwestern, a professor of medicine there, and have been in clinical practice for a long, long time. And I know firsthand, both from my own experience and the groups that I've run in my leadership roles, that without primary care, you really can't anchor a health system. And that's what I'm looking forward to hearing from Lisa today. So thanks again for joining us. Today we have Dr. Lisa Hirschhorn, who will be speaking to us about the importance of improving healthcare systems in global health, and highlighting the work of the Institute and the program in global primary care, which is set up to address challenges and gaps in the primary care space. Dr. Hirschhorn is a professor of medical social science and the associate director for the Center for Global Cardiovascular Health within the Institute for Global Health at Northwestern University's Feinberg School of Medicine. Starting as a public health and researcher and HIV clinician in the 80s, her research is focused on understanding the causes and developing feasible and effective solutions to the implementation gap and disparities in delivery, outcomes, and quality of care, especially in resource-limited settings in both the US and in Africa. As Director for Implementation and Improvement Sciences at Dane Labs, a partnership between Harvard School of Public Health and the Brigham and Women's Hospital. She led a team before she came to Northwestern, focused on developing more effective approaches to study and support approaches to apply evidence-based practices from the initial discovery of solutions through scale up and full implementation. Here at Northwestern, as professor in the departments of medical social sciences and psychiatry, and a member of the Third Coast Center for AIDS Research, her current work continues to focus on working to apply implementation science methods to measure and improve the implementation of quality and care in these countries. There'll be time for questions at the end, and we welcome you to submit them through the Q&A feature in the chat. And now, Dr. Hirschhorn, thank you for taking time to talk to us today. We look forward to hearing from you, and I'll turn it over to you.
Great. Thanks so much, Bob. And thank you, Rob, as well. And obviously to the Ryan family for the support and this vote of confidence in how important all of this work is in moving the work of Northwestern forward. Next slide, please. So I have no conflicts of interest to disclose, but I would like to disclose that I'm deeply indebted to colleagues who've shared knowledge, learning, as well as slides, including those from Ariadne Labs and the Primary Healthcare Performance Initiative, which I'll explain a little bit more. Work that I do with the Last Mile Health in Liberia is working to improve primary care there. The University of Global Health Equity in Rwanda, who's a partner at the Institute for Global Health, as well as the Havey Institute for Global Health, colleagues and collaborators, among many. Next slide, please. So I'm going to just talk a little bit about primary care and why are we actually talking about it. What do we know about measuring and improving primary care? And then really talk about what is the Northwestern Institute for Global Health and the program in global primary care doing to address these gaps? And what are some of the new challenges we face and the role of Northwestern in meeting them? Next slide, please. So Barbara Starfield is perhaps one of the sort of real strong voices in thinking about how primary care really needs to be the platform and what is actual primary care. And what she said is there's no such thing as a primary care service. There are only primary care functions and specialty care functions. And we know what the primary care functions are, and they are evidence-based. And I come from perhaps one of the most vertical specialty programs, which is HIV, and have really over time begun to recognize how primary care is absolutely core to the resiliency, the comprehensiveness, and the continuity that's needed by everyone, everywhere. Next slide, please. So what actually is quality primary care? So in addition to sort of the usual components of quality, which I'll talk about in a little bit, there's some things which are really very specific towards that. It needs to be the people's first contact. It should serve as the entry point into the healthcare system and the first source of care for most healthcare needs. It must be people-centered. So it really has to be organized around the healthcare needs of the people rather than their diseases. It should be comprehensive so that it's actually addressing the full range of needs of individuals, and it needs to be continuous. So it really should help people, whether we're talking about promotion, prevention, curative, or palliation. And finally, it must be coordinated as people are getting care from different areas to do that. And overall, it must be accessible so that it needs to be offered within their communities at a price that they can afford. Next slide, please. Now, we sort of over the last sort of 10 or 15 years, primary care has sort of undergone this refocus, which I think has been absolutely critical. People may know about a little over 40 years ago, the Alma Ate sort of call to action for primary care. And that's been sort of revisited when we start to think about universal health coverage, and that strong primary healthcare systems are critical to achieving this universal, equitable, and integrated health services. And this was restated in Astana a couple of years ago when the sort of world came together again to reaffirm its commitment to primary care. Next slide. Now, primary care and universal health coverage are obviously, very, very tightly connected. And the WHO has actually expanded the concept of primary health care to include not just the healthcare delivery, but also addressing some of the environmental and social issues. And this is absolutely critical to meet these sustainable development goals, which were took over from the Millennium Development Goals, particularly Sustainable Development Goal 3, which is really talking sort of about meeting these healthcare needs. Next slide, please. So why do we need to sort of think about, why do we need to do some things different? And the idea is that we need to really different systems and a strong primary care to deliver them and move from these sort of more traditional vertical programs of HIV and malaria and diarrheal diseases. And that's because, as you can see, there's a huge range from the beginning where we're talking about sort of deaths of newborns and children and getting them alive and thrive, all the way through thinking about things like cancer, again, the ongoing communicable diseases, also mental health and well-being, malnutrition and stunting, and obviously very, very important COVID-19, as well as preparing for future pandemics, and really rethinking about how primary care can actually work to be resilient and to provide these services is really the direction that we need to go. Next slide. So what are some of the challenges that we're facing? And the idea is really that these challenges are really system challenges. So a lot of the healthcare systems in the countries in which we work are not designed for longitudinal, coordinated, responsive care. They're really very much sort of one time. So you come in for your malaria, you come in for your diarrhea, or perhaps for your antenatal care and your delivery, but it's not really a lifespan approach. Often there's real challenges with poor quality. I'll talk a little bit about that. Regardless of which country in which you're working, there's been a huge rise of non-communicable diseases, and importantly, people with multiple morbidities. We see inequity of access and care really as a global challenge. In a number of countries as well, they've been increasingly challenged by migration and war, so they're working in very fragile settings in which primary care is still needed. And then finally, I think it's very, very obvious that the increasing number and the duration of these pandemics really is a challenge to how we build not just care now, but system resilience to be able to provide good care now and in the future. Next slide. So these are, so these are global. Low and middle income high countries are all facing these challenges, but these offer opportunities to learn from and with each other. And so this is an opportunity for Northwestern to both teach, but also to learn from the partners that we are working with and will be working with in the future. Next slide. So I talked a little bit about quality, and this is actually one of my sort of core areas that I've been working on for many, many years. And, you know, over the last decades, we've really focused on access, that people were dying because they didn't have access to care. And that's really flipped now because poor quality is killing, and there's 5 million deaths are estimated due to poor quality among people using care. And that's now outstripping the 3.6 million, still too many, that are dying from lack of access. And what you can see is here, blue is poor quality and orange is non-utilization, that this is really across no matter what disease you're looking at. And especially if we're looking at, for example, cardiovascular disease, a leading cause and growing cause of death in many countries, you can see that poor quality is a huge problem. And this is something that primary care is well situated to address. Next slide. Now, when we talk about quality, there's always been a sort of traditional thing of looking at it, which is really more the effectiveness. So the technical quality, are you getting the right drug? Is it the right dose? And the reality is that when we talk about quality, particularly in primary care, we need to have a much more holistic. This is from the Institute of Medicine. So it needs not just be effective, but also safe. It needs to be equitable, it needs to be timely, and very, very importantly, it needs to be patient-centered. And some of the work that's been done at Northwestern, integrating the voice of the patient, patient-reported outcomes, patient-reported experience, is really critical to make sure that we know how to measure this quality. And then also it needs to be efficient, because for it to be sustainable, it has to be something that the system is able to provide and provide in an efficient way. Next slide. Next. So what do we know about actually how to address these challenges and how to begin to think about it? Well, I think one of the challenges has always been is that in general, we've focused on what we call the 5 C's, right? So we've talked about first contact, continuity, comprehensiveness, coordination, as well as patient-centeredness. And then there was sort of more recently this focus on what used to be called the 4 S's, now called the 5 S's, which is all the stuff that you have to put into it. So it's the space and the systems, it's the staff, it's the stuff you need, the drugs, the equipment, as well as surveillance to see what's going on. And those are critical, but really they are necessary but not sufficient to convert all of this stuff that we put into the system into the quality care. And this is really an area where I think Northwestern is very well situated, you know, with a lot of the schools that make up the university, to think about what we call the 5 M's. So these include things, for example, like management. How do we actually get the people trained and able to convert these 5 S's into the 5 C's? how do we actually motivate the healthcare workers? How do we actually know that things are actually working in the right way we're doing? And then if not, how do we actually make that better? How do we actually do this kind of monitoring? And finally, how do we actually create and build multidisciplinary teams, something that, again, I think Northwestern has really been leading the way in terms of how we actually think of this model of care. So remember those 5 M's when we talk about some of the work that we're doing now and looking to do in the future. Next slide. So now that we've sort of talked about what is actually good quality care and what do we need for good primary care, where do we need to measure and to improve to actually achieve those goals? Next slide. So this is an initiative that I've been working with since it started over 5 years ago, called the Primary Healthcare Performance Initiative. It's funded by the Bill and Melinda Gates Foundation and is a collaboration that includes the World Health Organization, the World Bank, as well as Ariadne Labs and R4D and UNICEF. And the idea is, again, that often what we do is we look at these sort of outputs and the outcomes. Did people get better? Did they get the care that they needed? And those are very, very important. And again, often we also talk about the inputs. But what this sort of conceptual framework says is that we need to look deeply. We need to look at things like governance and leadership. We need to look at things like facility organization and management, availability. We need to look at access as well as population health management. And it's really only by expanding our lens of what we measure that we're going to understand where the gaps are and why we're not able to convert all of this stuff into the outputs and the outcomes, the health status, the efficiency and the resiliency that we need. Next slide. So what are some of the things that we're sort of learning about? So one of the things that people have always said is that, oh, the reason why you're not getting good primary care is that it's too many patients. And the World Bank has shown again and again that the answer is no, it's actually not too many patients. You look at the caseload per day, and I'm sure, Bob, you're probably very jealous of this. What you can see is actually very, very small numbers. And so there's some reason why, even when you have staff there, we're not actually being efficient in delivering the care we need. Next slide. Another one is that, well, maybe there's just not enough available providers. And actually the answer is that that's certainly true in some places, but often the answer is that many providers who are on staff are absent from the facilities. And you can see a tremendous range, the lowest tiers being Tanzania, but up to 40% in places of Uganda. And the majority of absence is approved. So this isn't about lazy health providers who are not showing up. This is about poor management. So remember, going back to that, one of those 5 M's, about how we need to actually motivate, but also manage our health, the available resources better. Next slide. Well, is it actually about knowledge? Well, the answer is sometimes yes, but often it's actually the gap between what people know how to do and why they actually do it. And this is very important work that's been done, led a lot by Jishnu Das out of the World Bank, where he actually looked at people's knowledge. So they actually asked, they used clinical vignettes, what would you do if somebody came in with this? And then they sent in standardized patients who actually either had or said that they had whatever the condition is. And what you can see, for example, is this enormous gap between what people know and what they actually do, whether it's diarrhea, whether it's tuberculosis, whether it's angina or asthma. So there's this gap, and we have to be able to both measure that and then figure out how do we actually understand whether it's the opportunity, the motivation, or the ability that creates this gap. It's not just more training. Next slide. The other thing is, again, we talked about, is that management matters. And I've said to many people that the M in MD does not always stand for management. And so figuring out how do we understand what are those competencies and how do we actually get people to do that. This is from a very large study called PMA 2020 that was done with colleagues at Ariadne as well as the Hopkins and in Ghana, the Ministry of Health. And what we found was that when you actually measure management, it actually does make a difference. So if you have it, both technical quality goes up as well as experiential quality. And so you can see, for example, there's better drugs that are availability, there's better integration, but we also see that there's things about respect as well as facility cleanliness. So it does make a difference. Next slide. Now, the other thing is that even if we got this really, really well, why don't people access primary care when it's available? So some of it is these sort of access barriers that we've spent a lot of time working on, financial, so out-of-pocket payment or user fees, as well as geography, the ability to actually get to where it is. But there's also a very, very important growing expertise looking at experiential quality, issues around disrespect, unmet needs, and lack of trust, all of which influence whether people will or will not access the primary care that we work to build. Next slide. So this is actually from a PMA 2020, from the one that was done in Uganda. This is from a household survey where people were asked about sort of why didn't you seek recent care in the last 6 months? And about 83% or so reported they were not sick. This was a very wide range of age. But if among the people who should have gotten care when they didn't, what they found was that some of it was indeed this geographic barriers. They couldn't get there, it was too long. But there was also a lot of financial barriers still, whether it was user fees or the cost of transport. And then equally important with issues around poor experience. There were other services that weren't actually available, as well as a number of other ones. And we've done some similar work of this in Burkina Faso, looking at people 40 and older. And we're again finding similar things around poor experience influencing whether or not people are actually willing to seek care and to seek care from the nearest facility. Next slide. Now, we also know that, when we sort of think about some of these ideas about barriers to care, that this is not across the board. And so we need to, when we're doing this measurement, to make sure that we actually disaggregate and look to see who is doing well and who is actually struggling. So no surprise, people who were more wealthy had fewer financial barriers. Interestingly, people who had excellent health versus poor health, which you would have expected them to actually need the care, they had less financial barriers. Very, very importantly, if you live in rural areas, it was more expensive for you to actually reach and to get your care. People who were able to go to a private facility obviously had fewer barriers. And interestingly enough, there were less for people with chronic preventive care versus acute care. And some of that is probably because there's fewer user fees for some of these things. For example, if you have HIV, a lot of care is often free. If you happen to have hypertension, you may actually have to pay out of pocket. Next slide. So what do we need to do? How do we need to change our measurements? So we still need to measure the technical quality. We still need to measure barriers to access, but we have to really focus on the voice of the patient. And again, this is something that I think Northwestern has really been a leader in, and work. It's been great to sort of collaborate with my colleagues at Medical Social Sciences and Claudia Hawkins in figuring out how do we actually build capacity for this. And we're working in Tanzania at this point. And so this is the idea, is that if you have what we call responsive care, so these, when people are able to rate highly things like communication, respect, engagement in shared decision-making, as among a number of them. So when you all put this together and create a score, if you look at people who have the lowest versus the highest scores, that overall people are more satisfied. These are what we call health system quality outcomes. So their needs were met. They were excellent at making me feel better. So people who had high responsiveness ratings were much, much more likely to say that. They were much, much more likely to say there was excellent quality of care. And even although there were more people who were willing to recommend the facility, we again see this. So it matters. We have to figure out how to measure it. We have to measure it in a way that is actually culturally and linguistically responsive. But we also then need to figure out how do we actually get people to use this information and, importantly, change the healthcare provider and the overall system behavior. Next slide. So what do we know then? So now we know that we have to measure better. We know that we have to look at these gaps, but how do we actually then make change? So this is the result of a multi-year study that was actually focusing on China. It was funded by the World Bank, that participated in through Ariadne Labs. And this is a slide that was given to me courtesy of them. And the idea was, after looking at all of the information and doing an enormous amount of key informant interviews, that there really emerged 8 core tenets of a successful primary-centered integrated model care, what we call primary care. So again, that primary healthcare has to be the first point of contact, and it has to be a trusted point of contact. That you need to have functioning multidisciplinary teams. This can't be the doctor alone or the nurse alone. That there has to be this horizontal integration from promotive and preventive to curative, rehabilitative, and palliative care. These are 2 areas, particularly the last 2, that are often not our focus, but the palliative care. I know that Ashi Dubé-Persaud is working with other colleagues to actually figure out how do we build capacity for that. Vertical integration. So it's not just primary care, and then you're off on your own to your secondary, tertiary care, but actually that type of referral system. And I would add to this, would include also community-based care from community health workers. Importantly, advanced information and communication technology. How can this help providers provide better care, patients actually access care, and this coordination? We need to help people figure out what are the clinical pathways for care and these dual referral systems. And very importantly, this is where I've spent a lot of my life, is robust measurement and standards and feedback loops to drive that change. And very, very importantly, accountability, because none of this will work unless there's accountability from the community, with the community, and also by the providers. Next slide. So does this actually happen? Like, are there any actually high performing primary healthcare systems? And the answer is yes, there are some, and there's ones that we can really do a lot to learn from. So I've been involved in some work, really helping to understand, working with colleagues in Costa Rica, how is it that Costa Rica actually has been succeeding? They've been one of the leaders in dropping mortality, increasing lifespan, and they've done it by really addressing some of these barriers we've talked about. So they rapidly increased insurance coverage, so therefore getting at some of these financial barriers, and associated that with life expectancy. They have a strong community-based primary care team, so multidisciplinary team, first point of contact, community-based. And what you're seeing is this declining in communicable disease mortality. Now they're struggling a bit with non-communicable diseases, but they're also adapting. Similarly with Brazil, you can see this idea about governance. So again, this accountability, and that's also been associated with significantly reduced mortality rates, particularly even in the states where there's better governance, they've had more impact. And then Turkey's another really good example where they really had this idea about enabling access for the entire Turkish population. They integrated thinking ahead of the game of systems targeting chronic diseases. And as a result, they doubled patient satisfaction and reduced mortality rates. So the answer is it's possible. It takes leadership, it takes management, it takes governance, it takes measurement, but we can actually get there. Next slide. So what are we doing? So just over the last year or so, we've really been focusing, and there's always been some work on global primary care, but a more sort of specific focus at Northwestern through particularly in the Institute for Global Health. Next slide. So the program in global primary care, the mission is to strengthen the global and local effort to improve global primary health care quality, access, and impact through partnerships and innovation in research, education, and service. And I want to just point out a couple of these words. It's through partnerships. So this is actually in collaboration with the countries in which we're working. It's this really important sort of triple areas. And I think as Bob already pointed out, the idea of education and training, as Rob already pointed out, with research, but also with service. And so all of these are together to really improve quality, access, and impact. Again, it's part of the Robert J. Havey Institute for Global Health. And the goal is really to identify areas where there are gaps in knowledge for implementation and delivery of this people-centered quality primary care, to build on and develop new collaborations, but at the same time to make sure that we are building research capacity and projects in collaboration with our in-country institutions. This is a long track record from the Institute for Global Health in large training grants, to support work to improve primary healthcare in our partner institutions and expand the training opportunities for Northwestern University students and faculty and with our in-country partners. And again, this leverages the deep expertise throughout Northwestern in the content, the methods, the experience, and the partnerships. Next slide. So I'm going to give you a little bit of taste about what's happening these days. And this is part of this is we have a Catalyzer project. Again, this is where we give sort of small amounts of money with a Northwestern University PI in collaboration with a principal investigator in partnership across the globe. So you can sort of see where we're beginning to expand. Next slide. The one star in the US is us in Chicago. And this is just a little tasting again of some of the funded Catalyzer projects. Again, they're designed to initiate new research or training projects. It's chosen through a competitive process reviewed by senior members of the Northwestern Institute for Global Health and other NU experts in the area. And these are just a couple of these, ranging from One World Surgery, which is expanding to address chronic and non-communicable diseases, work in Liberia with Snapper Hill Clinic, which is a private sector clinic, looking at primary healthcare research consortium, some work in Abuja, as well as other ones. And I'm going to go into a little bit of detail for a couple of these. Next slide. So in addition to the ones I'm going to talk about, there's a number of them are in development, ranging from strengthening primary healthcare in rural settings in Tanzania, looking at diabetes care in Belize, strengthening primary healthcare for adolescent population, potentially something looking at international classroom partnering grants, as well as one to look for vision care for low-income populations. And again, this is just some of our collaborations that we're doing within Northwestern. If any of these are of interest, please get in touch. If you have other ideas, get in touch as well. Next slide. So again, this is just a few areas where the program's working that I'm going to be going on from Togo, Uganda, Nigeria, in Abuja, Nigeria in Lagos, and finally in Liberia. Next slide. So this was a study that was done with a non-governmental organization, an NGO that's been working in Togo for many years, strengthening primary care. It actually started off doing HIV and then expanded out to primary care. And the question was, does strong and trusted primary care maintain essential services during COVID-19? So looking at the disruptions in essential primary care during the pandemic, and then understand what were the factors that were related to the healthcare utilization. This is the area that we focused on in Togo, an example of one of the capacitated primary care centers. Next slide. Next slide. And what you can see, it's a little bit hard. I know it's a little bit small. So the blue is actually the capacitated primary care systems. This is the ones which were not. And what you can see is that in the setting of having salaried and supervised and trained community health workers, as well as these capacitated sites, that you have this sort of normal kind of coming and going. There was indeed a dip as the initial pandemic hit, but then there's been this rapid recovery and resiliency. And when we did this qualitative work, I said, this is from a healthcare provider, when we had a positive COVID-19 case, I told myself that it's over, we won't even consult, but that hasn't changed. Patients kept coming, everything is going normally. And then from a community member, because of the pandemic, when my child got sick, I ran quickly to the health center. I thought to myself, maybe this is the disease. So again, it shows this trust that they have. And then community health workers are playing really a pivotal role. When if I'm afraid to go to the center, I can go to the community health worker to get the care. Because if I know that there is a suspicious case, I'm afraid to go. So I go to the community health worker. And you can see that it was not only that they were paid and supervised, but one of the priorities was actually making sure there was PPE for the community health workers, as well as that they were prioritized for vaccination. Next slide. Some of the work that's just starting, there's a very interesting one from KIEFO, which is addressing malnutrition through rabbit breeding in Uganda. This is Dr. Steker at NU and Nguyo in Uganda. Very, very high rates of malnutrition, largely due to lack of protein in the diet. And so this is a really exploratory one, the potential to sustainably combat poverty as both to create income, as well as malnutrition through rabbit breeding, looking at protein intake, income generation, and food security with an evaluation planned. Next slide. Another one, which is really sort of modeling, and this is one that I'm working with Dr. DK Oji, but Jen Chengdu is the person who's really doing all the work. This is embedded into a larger study being led as well by Dr. Mark Huffman. Elevated blood pressure is an enormous problem globally and in Nigeria. And we know that actually, again, remember this idea of continuity in primary care, that if you start people on drugs, you actually got to get them to stay. You have to have retention. And so the study is going to be using system modeling to figure out what are the best ways to improve retention and hypertension care. One of the first things that we've seen, these are the sites that are involved in the overall overarching study on improving hypertension, is that even at the very beginning, there's tremendous variability in how well these sites are at retaining people in care. And so the idea is to provide both quantitative and qualitative barriers on these facilities and facilitators and barriers and strategies to develop and then test system-based approaches to improve retention. Next slide. This is another one that's just beginning. Again, we're focusing on areas where there isn't a lot of work these days, and the aging population is certainly one of them. Globally, this is happening across the globe, and we need to sort of figure out how to improve both quality of care and quality of life and care. The World Health Organization has developed guidelines for these sort of age-friendly health services. This project is in collaboration with people we've been collaborating with in a number of other areas, the Medical College of Lagos and Lagos University Teaching Hospital. And the idea is to measure the capacity currently of age-friendly health services in Lagos in Nigeria to then guide interventions. I'm doing this in collaboration with Dr. Balogun and Onganyemi at Luth. And this is actually, I was in Nigeria for a different work, and we are actually invited by the Primary Healthcare Board of Lagos to present on this project. So you have all the different directors here, and really sort of discussing and very excited about the project to move this forward. Next slide. And finally, this is one that is building on some existing work and collaboration that's been done with Sanabria Hill Clinic in Liberia. It's one of the leading primary healthcare delivery sites. It's in the private sector, and it's been supported in the past to provide education for COVID response. And so this Catalyst project is actually a quality improvement project. So they're really focusing on how do they use really traditional quality improvement as well as certification to improve the quality of primary care. Combined with that, they'll be conducting quarterly case conference virtual webinars with Northwestern University clinicians. Again, this idea of creating these partnerships. And then what the goal is ultimately to develop as a center of excellence for primary care in Liberia, supporting the growing private sector, what's called the Healthcare Federation of Liberia. And this is being done by Cara Palamonte at Northwestern, as well as Barcé Sirleaf. Next slide. So what are some of the ongoing new challenges we need to face, and what's the role of Northwestern in meeting them? And hopefully, as you're listening, you're thinking, that's something that I might be able to get involved in. Again, we bring deep expertise in research, in training, in primary care, in collaboration and partnerships. Our vision is to address understudied and emerging gaps in primary care to develop innovative and relevant solutions to test. So for example, there's a lot of work that's happening in under 5 mortality and in neonatal, but there's very little in adolescent primary care. To provide new opportunities for learning and teaching for faculty and students, and to develop as leaders in this type of collaborative and effective research with high impact, and integrate with the existing centers in the Institute for Global Health, as well as other work across Northwestern. Next slide. So there's a lot of questions that I think we need to begin to think about, and really interested in hearing from you about where you think we need to go further. So how do we better understand maintaining effective primary care before, during, and after health system shock? So again, resiliency is the ability to provide good healthcare in good times and in bad. What are the best models of care delivery for aging populations, particularly those with multi-comorbidities in low resource settings? How do we increase the voice of the patients and community to improve primary care, not just by measuring PROMs and PREMs, but also to get people to use them? How do we strengthen training opportunities and impact, both for Northwestern as well as for our partners? And finally, how do we expand the scope of primary care in these settings to address newer under-prioritized challenges, vision, adolescent health, hypertension prevention, to name just a few? Next slide. So just join us. You can visit us online. This is the program for global, which again, it's our, and this is the thank you very much, Kristen, for the just new hot off the press website. So please check it out. It has a lot more details about the catalysts and also how to get in touch with us. Next slide. So I just want to sort of thank again the supporters for the Havey Institute for Global Health, to the many partners and collaborators, both at Northwestern as well as in the other countries. Without that work, we wouldn't be able to do what we do. And obviously, very, very importantly, to the frontline workers for their dedication, focus, and resiliency across the world, both during COVID, but also before COVID and afterwards. This is the link to join the Institute for Global Health, as well as the program in primary care. And for general inquiries, this is the to contact Global Health Institute at northwestern.edu. So I want to open this now for questions from the audience, comments, reflections, and any suggestions that you might have. We're a pretty new program and we are looking to grow. Thank you.
Thank you very much, Lisa. That was a great presentation. Really, really very much appreciated. Please put your, if you have a question for Lisa, please put it in the chat box and I will ask her the questions. That's the format works a little better with a group this big. We have one question in here now. What are your thoughts about the impact of climate change on primary care?
Yeah, I think that's an incredibly important question. And I think one that we haven't sort of explicitly dove into, but really important. I think it's going to have a huge impact in a lot of different ways. First of all, it's going to have a huge impact in terms of access. So if you were thinking about places which have already been disrupted because of climate change or are undergoing challenges, how do we ensure ongoing access? I do some work in Bangladesh, very, very low-lying areas. How do we sort of convert from fixed facilities, for example, to ones which may be water-based or otherwise? Second of all, we're going to definitely need to continue to retrain and capacitate the systems. So, for example, in a number of countries, such as in Rwanda, there were places where they never saw malaria. And so the providers there just didn't have to focus on it now, but because of global warming, we're beginning to see that as well. And then finally, obviously, the disruption in things like food chain, in increasing rates of poverty. So I think we do need to do that. There's, the concept of sort of the of a more sort of integrated approach to one Earth, I think is the name for it. But if there's people who are interested in that, please do get in touch. I think it is an area, sadly, of growth, but one in which we need to become a new concept of resiliency, not just to the usual shocks of pandemics, wars, migration, but also climate change.
Great, thank you. Another question here. Is there a current NU objective working towards equitable COVID vaccine distribution in low and middle income countries?
So I'm gonna sort of bring that to other people to respond. But what I will say is there's been really very strong work that is showing that primary care is really the route by which we're going to be able to address issues around vaccine hesitancy, as well as the trust that's needed and the idea of when people are coming in. So the idea about where people have a contact, that's an opportunity to provide the vaccinations. I can speak only in some of the countries in which I'm working. For example, Rwanda, which has really worked hard to prioritize who's getting the vaccine and how they're getting it, and integrating it into the existing primary care system, largely through the community health workers, to do both education and sort of similar work that's happening in Liberia to address that. In terms of other types of delivery that going beyond primary care, Rob, do you want to comment on that?
Yeah, there is a lot of experience with vaccine delivery in low and middle income countries. I mean, everyone knows about UNICEF and all the stuff they're doing. I think that one of the big challenges is in some of the vaccines, of course, have a cold chain supply thing that is really going to be tough for certain areas. Now, some of the vaccines don't have as much problem with that, but those tend to be a little bit weaker vaccines. The AstraZeneca vaccine has less activity in some of these variants that are out there. So, I mean, it is going to be difficult. Now, there's a COVAX group that is responsible for promoting vaccine delivery. The current administration has just promised 500 million doses. It's interesting to note there's 2.5 billion doses have been administered worldwide. It's not a small number. I mean, it is happening, but that of course has to continue. I don't know. I mean, this pandemic is not going to be over until everybody in the world is vaccinated.
And I would argue that, certainly the vaccine campaigns are a very, very important way of doing this, but that ultimately, if you believe that you're going to need to have ongoing vaccination, it's not a system that's been set up for adults, but certainly has for kids. And primary care has always been sort of the backbone for that. So I think thinking about how that can be done, particularly as we get more easily available and transportable vaccines, I think is something definitely we should keep an eye on as a potential area to look.
Yeah, I mean, although we only have the 3 vaccines here, there's, I think, 8 approved worldwide, and there's 100 in development. I know the Indians are using that DNA vaccine with the pressure gun thing. There's all sorts of stuff going on. So I think some of the technologies are going to be better serve, primary care delivery in many low and middle income countries, just in general. Mm-hmm. Got another question here. Great talk. Found your point about better facility management is associated with better outcomes. Could a case be made for shifting focus to management change rather than more medical protocols? And how does that happen? Just curious.
So I think this is an opportunity for a yes and response. So I don't think it's either or, but I do think it goes to this idea about, how much of this is the skills of people's of ability that we can actually address through better training, through some of the very innovative approaches that Northwestern has been developing in terms of simulation. And then how much of this is the opportunity to do it? So you could train me to use the right medication. If I don't have the right medication, I'm not going to actually be able to give that, which is sort of where management comes in. And then I think a lot of this issue about motivation and burnout, and how do we make sure that people are there and able and providing the respectful, people-centered care that's actually needed. So I think the answer is it has to be both. I think, when we start thinking about system change, which is often, a lot of challenges in quality are not an individual's challenge, it's really a system challenge. It is where management needs to come in. Now, it turns out that measuring management at these primary healthcare facilities is not the easiest thing in the world. There's the World Management Survey, which was developed for much larger institutions, and we've been working for a couple of years to figure out how to simplify it. A lot of the service readiness assessments of things like SARA and SPA, which are developed by WHO and USAID, the management questions are very, very basic, shall we say. And so again, this is an opportunity, I think, for engagement for people from Kellogg, from other groups within Northwestern, to really think about how do we actually make this in a way that is measured, in a way that can be used iteratively to feedback and improve systems. And then where are the trainings that are needed, and how do we actually build the capacity for management that's needed within those primary care settings. Sign up, be in touch.
Yep. No, that's great. Let's see, I think there's, yeah, thank you very much was the last comment there. So Lisa, maybe I'll ask a question. If anyone has a question, please put it in the Q&A box. So where do you think, Northwestern, I would have to say, is we provide a lot of primary care through the internists who are here. And we have a general medicine division and so forth. But where do you see us fitting in, especially globally, because of course we're here in the Global Institute for Health. But how can Northwestern really get into this with both feet on the ground?
Yeah, I think it really is, building from the strengths that we have, and then identifying where there are people who have not, where are the areas that people have not been focusing. And again, the care of older individuals, whether we're talking about work at the Pepper Center or the Bueller Center, and in primary care, understanding how to create a system that is able to holistically both improve quality of life, reduce morbidities, and then manage the morbidities when they occur. I think that's a very, very important niche where with Northwestern can help work in. I think, we're already really leading a lot of the global cardiovascular work, and, the work that's being done with Mark and Huffman and DK is primary healthcare based, a lot of it. So the idea is, how do we not get away again from this vertical program to really integrate it, and learning from some of the work that's happening, here in Chicago, whether it's Quartet or work that Nami Kandula is doing about sort of community-based work. I think adolescents have been, well, sort of anybody from 5 years until you become pregnant as a woman, and for men until you actually get a disease, has really been a huge gap in understanding primary care. And, there's, I think, been increasing sort of focus on adolescents around HIV, but not around primary care. And so really excited about some sort of emerging catalyst that's happening between Lurie and Lagos College of Medicine to really begin to understand what are the needs and what's the best models of care for adolescents. I think that there's, again, this idea of management and how do we sort of accelerate the improvement? How do we build capacity for people to do this type of systems change? Whether it's sort of the work that Cindy Barnard's working at the hospital, whether it's through the Kellogg School. So understanding what is a feasible, acceptable, and sustainable approach using implementation research language, I think is really critical. And then finally, I think, Northwestern is one of the leading places for understanding how to measure patient-reported outcomes and expanding into patient-reported experience, and really thinking about how do we actually get people to understand the value of that and incorporate that into the feedback to improve care so it's more responsive, so people are more willing to get it, and that it actually is more able to meet the needs of the individuals.
We have another question. As you work with disadvantaged countries, how does data get collected and shared with other systems? Is the data collected and shared?
So, there's two sort of ways of thinking about this. I think it's a very, very important question because, my feeling is, data is sort of the heartbeat of what we do. I used to work with a large nonprofit, and I went in there and I said, I don't do what I call faith-based monitoring, which is like, I think it's going well, I hope it's going well, but I'm not sure. So it's really working within the systems, ideally, to strengthen what they're already doing. And there's some very good work that's doing about sort of a data use, data improving quality. So the first thing is, how do we actually better use the data that we already have? The second is, how do we actually help people stop collecting data they're not using? So that's, that sort of thing. And then there are times, particularly when we're doing research and we're thinking about generalizable knowledge, that we do need to collect additional information. So patient-reported outcomes, for example, are not routinely measured in any of the systems that I've been working in, with the exception of some HIV clinics that look at things like quality of life and depression. So how do we think about working with the partners, and very, very importantly, with the partners with deep stakeholder engagement, to sort of add on some of this additional measurement to understand, are things working or not, and always thinking towards how does this integrate into some of the routine healthcare systems. So I think, luckily, I think we have, at least at Northwestern, have a very strong commitment to get away from what used to be called safari research, where you'd sort of pop in, grab data and leave. But that really all of the work, and I think, Rob, a lot of the work that you've done with the countries in, for example, Nigeria and Mali, among many, is really this idea that it is a partnership, and that the data are owned by the country, and that we are there to sort of help people think about how to be more creative about what we're measuring, how we're measuring it, and very importantly, how we're using it, and then how we address the problems that actually emerge.
Yeah, just FYI to everyone out there, data science has become an incredible focus that the Fogarty Institute for Fogarty International Center at the NIH is really pushing now. And they just are in the process now of funding the first group of data science centers throughout the low and middle income countries, because it's so important. You've got to be, you can do all this great work, but you've got to be able to manage this data. And that's one of the lacking areas in the whole research portfolio of many of these countries. We have, Li Feng Hu and I have a research training grant, which is really focused on informatics and data science. And that's in Nigeria right now. And it's sorely needed. And I think, we're at least pointed in the right direction. A couple more quick questions, then we have to wrap it up. How are new partnerships formed? Any plans for getting into the Middle East or refugee care?
So that's, I think, a really important question there. And I think the answer is that I know Northwestern has certain sort of steps to go through, whether it's something that is just an initial partnership, or whether it's actually a more formal, longer standing relationship. The sort of more informal partnerships, it's one of the reasons that we do the Catalyst, which is to sort of see, is this a partnership that's going to work for the partner in the country as well as for Northwestern? Does it really meet our goals in terms of not just sort of small projects, but also projects that will continue to grow. I'm doing a fair amount of work right now with EMRO, which is Eastern Mediterranean Region Office for the World Health Organization. And so I think there's, sort of opportunities through them. We're looking at primary care, particularly in fragile and conflict affected settings. But there's also, obviously, there's the Northwestern Qatar University campus, which I'm sure I'm misstating, as well as other ones. But again, if there's interest, just get in touch, and we're happy to sort of reach out for that as well.
Yeah, and we'll take one more question from a resident. Thanks for the great talk. Are we as residents able to do electives abroad? If so, how should we get started? If we have connections abroad where no relationship has been established at Northwestern yet, can we still visit those sites? Thanks again. I don't know if this is for me or for you.
I was going to say, this is probably more for you. I would say that I know in the past, there's been a tremendous amount of opportunities. Obviously, COVID has put a challenge into that. I would say, first look, well, I'll leave it to Rob to say if and when people can go, but I would say it's generally best to go to places where there's an existing relationship. I would say if there's new ones where you might have a relationship, but not otherwise, again, just come to one of us at the Institute for Global Health, particularly, Rob or Kate or Ashti and Bill Leonard for the training, and Leah Neubauer for those questions. But I don't know about when the light changes from red to green.
Yeah, it's you really touched on the reasons why we actually have sponsored sites. Before the first Center for Global Health was started, there was no rule. We had probably 100 sites around the world. Most of them ended up being kind of dormant. Some of them, the experience was, plus minus, and they weren't really giving a great experience, over time. So we trimmed everything down. We have centers that we work with. We get rid of ones that don't work, and we add ones that do have something to offer. And we know the people on the ground. It makes a whole lot of difference if you have experience and you keep going back to the one site. It's good for everybody. So you can go pretty much anywhere. You have to apply, and it gets evaluated. Sometimes the non-sponsored sites have a little bit more restrictions on them. But we can take it one by one. And I think, and Kate just put in I think in the chat box here, that the kind of the way you go through the process. For McGaw residents, see the guidelines for international electives here. And the website is there. So there's a whole set of guidelines here. We're not trying to limit anybody from doing good things, but we want you to have the best possible experience. And we want sustainable sites that are going to give a good experience. All right, so let me just conclude. Thanks, Lisa, for sharing this insight and your leadership in global primary care. Thank you for the audience for joining us today and for your questions. We invite you to join us next month for the annual Havey Institute for Global Health Gala event, which will be held virtually. That's going to be on the 10th of November. And we'll hear from global health leaders, faculty, and students who will highlight our recent achievements and projects and how the Havey Institute for Global Health is working combating the COVID-19 pandemic as well. More details will be shared shortly, so please stay tuned. And again, thank you very much for joining us today. For those that have registered, a recording of the webinar will be shared via email shortly. And this concludes today's webinar. Thank you very much for coming, and thank you again, Lisa.
Thanks, Steve.